I'm going to give you a 2012 update with a few learning objectives. First, that venous thromboembolism, which encompasses pulmonary embolism and deep vein thrombosis, or DVT, leads to chronic thromboembolic pulmonary hypertension and to post-thrombotic syndrome of the legs, which can be chronic, lifelong problems. I'll then focus in on pulmonary embolism and share with you the most up-to-date methods we have to detect high-risk patients who need extra special help being treated medically for pulmonary embolism. I've already told you about rivaroxaban as oral monotherapy for deep vein thrombosis, and then I'm going to focus in on rivaroxaban as monotherapy for acute pulmonary embolism. We'll discuss advanced therapy, fibrinolysis, vena cava filters, and embolectomy. And finally, I'll talk about something that might at first seem a bit counterintuitive, the use of aspirin to prevent recurrent venous thromboembolism. Just to remind us that pulmonary embolism is still a potentially fatal illness. This is a 69-year-old woman who could not be saved, who presented with an unprovoked idiopathic pulmonary embolism, both in the right lung, as shown here, and in the left lung. We have to keep this perspective in mind. And furthermore, pulmonary embolism has a much higher mortality rate than acute myocardial infarction. It's more difficult to diagnose than myocardial infarction, and we don't have the available revascularization therapies of percutaneous coronary intervention that we have for acute myocardial infarction. Among survivors, as many as 2 to 4% of survivors of pulmonary embolism will develop the devastating chronic illness of chronic thromboembolic pulmonary hypertension. And the pathophysiology has two parts. First, there is persistent macrovascular obstruction. This can be handled with a complicated surgical operation to remove the clot. But much more difficult to control is a persistent vasoconstrictor response, particularly in the smaller vessels of the pulmonary arterial tree, and this requires the use of complex pulmonary vasodilator medication. Now, in family practices, internal medicine practices, we see a lot of patients who present with the post-thrombotic syndrome of the legs. This carries no mortality, but it negatively impacts the quality of life. You can see various stages from just some venous ectasia or hyperpigmentation of the skin. At the other extreme, ulceration can develop. There's also leg edema, particularly in the ankle and the medial malleolus. And this requires the use of vascular compression stockings. Some people have to curtail their work, particularly if they're on their feet all day, or their social activities. Now, pulmonary embolism is a wide spectrum of illness, from patients who are going to survive to patients who might have a potentially fatal disease. And we now have the tools available to detect high-risk patients. We can look for elevated biomarkers such as troponin. We have ways to image the heart to look for right ventricular volume and pressure overload. I also want to point out that merely being admitted to a hospital in the United States in the weekend, that would include today, while we're all here, is in of itself a risk factor for a worse outcome. What we see on the chest CT scan is a two-dimensional structure of the heart, and we can look at the right ventricle and the left ventricle. But that's really what we're interested in, is the volume of blood in the right ventricle compared with the left ventricle. And under normal circumstances, the right ventricle is smaller than the left ventricle. Here, we see, by doing some specialized imaging and reconstruction, looking at an axial view of the heart and a sagittal view on chest CT scanning, that this lilac color representing the blood volume in the right ventricle is much greater than this peach-colored area here of the left ventricle. In fact, it's 60% greater. And this is an example of right ventricular volume overload, a risk factor for a poor outcome from pulmonary embolism. On standard echocardiography, we see an enlarged right ventricle. The interventricular septum is pushed toward the left ventricle and compresses it. And most patients with pulmonary embolism have diastolic dysfunction, as evidenced by this increase in A wave. We can risk stratify patients with pulmonary embolism really by eyeballing their right ventricular function on an echocardiogram. And those who have a failing right ventricle, right ventricular hypokinesis, where the right ventricle is not contracting and relaxing properly, have a much higher likelihood of death within the first 3 months than patients with pulmonary embolism who present with normal right ventricular function. Now for the weekend effect. There is some good news in this slide. This shows the mortality rate from pulmonary embolism in the United States over the past decade. And you can see it's a general trend downward. But look, for every year, the mortality rate is about 2% higher for those patients who are hospitalized on the weekend, defined as 5 p.m. on Friday until Monday morning at 8 a.m. And I think this points to our systems of coverage and perhaps indecisiveness of what to do with these patients over the weekend. And I think for those who are working on health policy and systems reform, this area is ripe for further research and innovation. So we need to risk stratify our patients with pulmonary embolism by looking at their clinical evaluation, the size of the pulmonary embolism on the chest CT scan, right ventricular size and function on echocardiogram and CT scan, the presence of abnormally elevated cardiobiomarkers. And what we'll find is that about 70% of the patients are low risk, and they should do very well in anticoagulation alone. But 30% of the patients are clearly at higher risk, and for these patients, we should go through the thought process of whether they'll benefit from advanced therapy such as thrombolysis or embolectomy in addition to anticoagulation. The advanced therapies include systemic administration of TPA, tissue plasminogen activator, catheter-based reperfusion, placement of an inferior vena cava filter, or open surgical pulmonary embolectomy. Here you see a patient of mine, a 44-year-old woman, and before fibrinolysis, she presented with a massive right pulmonary artery embolism. After fibrinolysis, she had 2 hours later, after a 2-hour infusion of TPA, she had marked improvement angiographically of her pulmonary arterial tree. But we want to do more than have a nice picture of her pulmonary arterial tree. The important finding is that her right ventricle was failing prior to thrombolytic therapy, and after thrombolytic therapy, her right ventricle has normalized in size, and normal right ventricular contraction has ensued. These are national data that have just been published this year, showing that patients who receive thrombolytic therapy, if they are hemodynamically unstable, in other words, patients whose blood pressure is threatened, if they receive thrombolytic therapy, their mortality rate is about 15%, but without thrombolytic therapy, it approaches 50% for patients who present to the hospital in an extreme condition with a low blood pressure, suggesting that thrombolytic therapy is the way to go for patients with massive pulmonary embolism. We also have catheter techniques, mechanical fragmentation, hydrodynamic instrumentation, ultrasound accelerated fibrinolysis, and suction embolectomy. This is the largest pulmonary embolism ever removed through a catheter intact in one piece. It's 17 centimeters in length. This was removed from the now defunct Lynette Hospital in Paris. This lucky Parisian man collapsed just outside the hospital and was saved with a greenfield embolectomy technique. At Brigham and Women's Hospital, we have one of the largest experiences in the world now with open surgical embolectomy. This particular surgeon operated on this patient of mine that I referred him, and he had one of those old-fashioned flip telephones, and our elevators are very slow. When he flipped open his phone, I thought he was going to show me a picture of his wife and kids, but this was the picture he showed me, the embolectomy specimen that he had removed. We have a survival rate well over 90%. The inferior vena cava filter also plays an important role in lowering the death rate from pulmonary embolism. And it appears again from national data that the vena cava filter shown in the gray bars really has an advantage over no vena cava filter for patients who receive thrombolytic therapy, who are hemodynamically stable, or for patients who are unstable with a low blood pressure. It seems that the placement of a vena cava filter can be life-saving and lower the case fatality rate. The vena cava filter appears to have no role for totally stable patients who do not require or receive a thrombolytic agent, no role in terms of mortality reduction. Back to the Einstein program that I talked to you about for DVT, the Einstein program tested rivaroxaban against enoxaparin as a bridge to warfarin for symptomatic acute pulmonary embolism in the largest ever study done in pulmonary embolism patients in the world, more than 4,800 patients. And rivaroxaban, given as oral monotherapy without any injections of anticoagulant whatsoever, was non-inferior to enoxaparin bridging to warfarin in terms of efficacy and overall clinically significant bleeding. But look at major bleeding. Rivaroxaban in this Einstein pulmonary embolism trial cut the major bleeding rate in half. And it was the type of major bleeding that we clinicians fear the most. For intracranial bleeding, bleeding into the head, there was one intracranial bleed with rivaroxaban. There were 10 intracranial bleeds with enoxaparin bridging to warfarin. Another one we fear is retroperitoneal bleeding. There was one retroperitoneal bleed with rivaroxaban, and there were 7 retroperitoneal bleeds with enoxaparin bridging to warfarin. Well, moving on from the acute treatment and management of pulmonary embolism, how do we, over the really long term, prevent recurrence of DVT or recurrence of pulmonary embolism? The old teaching was that the pulmonary embolism and the DVT are red clots, and we use anticoagulation. And acute coronary syndrome is a white clot. We use antiplatelet therapy. Of course, we learned this morning that we also can use antithrombin agents and reduce mortality in acute coronary syndrome. So there's a crossover effect because we've just learned that we can use aspirin for the long-term prevention of recurrent DVT and pulmonary embolism. Because in fact, there are some platelets in the DVT and in the pulmonary embolism clot. And it's not the number of platelets that count, but because the platelets that are there, they release polyphosphates, microparticles, pro-inflammatory mediators, and they interact with the neutrophils to really be, as Dr. Libby has taught me, cluster bombs of thrombosis. And the aspirin can really stop this process. Now, in a randomized controlled trial published earlier this year, the recurrence rate with placebo, these are patients who had been treated for at least 6 months with anticoagulation, patients with DVT and pulmonary embolism, the recurrence rate on placebo was 11% per year, but patients who received baby aspirin had a recurrence rate of just about 6% per year, or half. So the modest little aspirin tablet cut in half the recurrence rate of DVT and pulmonary embolism after 6 full months of standard anticoagulation. So my take-home messages for you are that chronic thromboembolic pulmonary hypertension and post-thrombotic syndrome of the legs are late effects of venous thromboembolism, and that we as clinicians have the responsibility of rapidly and accurately detecting high-risk patients, ideally before they become unstable. Coming on board very soon is rivaroxaban, which will provide us with a great tool, particularly in that 70% of totally stable, low-risk patients, of oral monotherapy without requiring any injectable agent whatsoever. And thrombolysis and vena cava filters do appear in terms of these large U.S. registries to reduce the mortality rate in unstable patients. Venous thrombi contain activated platelets and pro-inflammatory mediators, and their harmful effects can be suppressed with aspirin. Aspirin appears to cut in half the rate of idiopathic venous thromboembolism following 6 to 12 months of initial standard anticoagulation. Thank you very much.
It's remarkable to me the parallels between the way we have seen the treatment of acute coronary syndromes change over time. And here we are, I feel, almost going through a similar transformation in pulmonary embolism. Acute coronary syndromes were initially, especially ST elevation MI, were initially treated with systemic fibrinolytic therapy. And pulmonary embolism, when it's massive or submassive, has been initially treated with fibrinolytic therapy. And then we shifted gears a little bit for acute coronary syndromes and decided that catheter-based or cath lab approach was preferable. Do you envision this same transformation for pulmonary embolism?
Well, Greg, you and I are running an FDA-approved investigational study of the ultrasound accelerated program, which I think has the promise of leading to much more rapid dissemination of this new technology with catheter-based reperfusion. And the technique that's used with the echoes is much more simplified than some of the previous activities. So we'll have to wait and see what our ongoing study shows, but I personally am optimistic.